Well, good evening, everyone who's present and online via Zoom. Thank you for the opportunity to speak with you this evening. This evening's focus is DEI, and I call it not only diversity, equity, and inclusion, but delivering excellence and impact. So this evening's focus topic is cultivating a culture of unity as community, how DEI advances the sacredness of health in medicine and healthcare settings. Since I have the opportunity to work with the better part of the 6,400 healthcare systems that are out there, slightly over 4,000 I currently work with, I know these opportunities within this, taking what's learned in med school to healthcare to be tried and true. But the beautiful thing is that DEI keeps advancing, and so I'll be able to bring you up to speed in whatever your role is within healthcare today and in the future, how it can be applied. First of all, there is no financial interest or arrangement with Creighton University. This is just my own professional experience. This evening, we're going to discuss 5 different elements, from the reality of DEI and its need to how it's applied within medicine, patients, and healthcare, the strategic elements and how it is applied via impact and cost, and then innovation, which helps propel it moving forward. I like to think of DEI as the mirror effect. Do unto others as you would have them do unto you. And I also ask for it to be the honor of the sacred self, human-centered care. And when we think about it in those contexts, we can easily see how diversity and inclusion and equity are so important to who we are as person and within the global community itself, especially in healthcare. So if I were to ask you what color compassion, love, and kindness are, or what equity, quality, and safety look like, or who is the face of DEI, we should all be able to have that looking glass effect, that mirror effect that would say each and every one of us. When DEI is applied, it is the difference of nearly $1 trillion over the next 2 years in healthcare spend, which also is the difference between our most underserved community members having longevity added between 5 and 15 years. It reinforces the mantra of first do no harm, and it also is the moral imperative of human-centered care. Many of you may have heard of patient-centered care. It's now in the healthcare ecosystem, it's now called more human-centered care. So you each have questions. You on Zoom should have had this link. We are not going to be discussing these questions. These are more for your introspection in what your role is today. And it would be interesting for you to maybe take a look at it a couple of months now, and again, a year from now, to see how your thoughts and how your implementation and your role is within DEI. So I always think it's good to have an exercise to think about how DEI is important. As I noted, DEI for myself and my work day to day as a CEO is delivering excellence and impact. I like to think of things as 2 things. One, it's great to be well-known, nationally recognized within what your healthcare grants and spend and outcomes are, but really I look at DEI as the perspective of in human-centered care, what can we do if we addressed our least healthiest patient? And when we say that we're only as healthy as our least healthiest patient, that gives us a great understanding and a prompt astuteness to know that that needs to be a continued priority. It's also the unity of understanding, choosing to work collectively versus in isolation, in silos, and having those biases and false narratives that are often the natural default button. It's recognizing, as I already stated, the sacred self. It's recognizing your divine spark of who you are and who you embody as a vessel of serving others in the wholeness of care. I also call myself a chief example officer, and I think we all have the opportunities as healers and communicators and doers to always be chief example officers. DEI is also the celebration of strengths. It's taking a look at a multifaceted approach of recognizing the rich tapestry of who we are as patients and providers, educators and learners and activators, who we are in the celebration of culture and language, customs, understanding, and talents. And then it is bringing balance and harmony, perspective and understanding in a reflective mirror of sorts. So if we look at just these highlights in purple, we'll see that when DEI is used at its optimum, there are 96% of those that have been surveyed in healthcare, they believe that DEI is their highest goal. Their most common definition We always look for opportunities of least path of resistance, and the most best commonality is equity aims to ensure equal treatment, access, opportunity, and advancement for people and employees in workplaces. It is also the state of being in which everyone has a fair and just opportunity to acquire and attain their highest level of health. Now healthcare is really looked at as ecosystems. There are currently, if you look at each of these pieces and parts and how they fundamentally work together, we have over 17.7 million people working directly within DEI. These are the risks without DEI, and I think this is a great slide to refer to perhaps in the future. Dr. Johnson, when you are looking at service as a physician and where some of those risk factors are, when you don't have DEI, this is what you would have as the difference between a wellness opportunity and those that are deficits. So just an example is lower life expectancy, mental health, hospital and surgical diabetes, chronic health, cancer outcomes, and diabetes. So when we look at the largest spend of where DEI can be most maximized, if we were to really split that pie of healthcare, diabetes, $306 billion, oncology, $246 billion, mental health, $282 billion, and OBGYN or child maternal health, $22 billion. So you have two parts. You have the sacredness of the self and how you approach human-centered care, and then the outcome, which translates to not just passion and wellness, but dollars. These are the dimensions of DEI, from race to age, sexual orientation, parental status, physical, mental ability. These are the sacred elements. And when I say sacred elements, I'm not just saying applying those within a faith-based organization. I'm saying these are sacred truths that we need to recognize in our roles, from investing in children to healthy aging, providing a safety net, recognizing the welfare mix. Again, putting that patient at the center. The United Nations, these are their DEI goals, and those are often mirrored in many of the 6,400 hospital systems, recognizing that in a global community within a nation, these are some areas that we need to work on individually and collectively. So some of the gaps measures for equity, inclusion are anywhere from recognizing since the pandemic, we have an increase in diseases all the way down to more of a One Health component, which is the last dot point, which is environmental imbalances throughout water, climate change, or climate sensitivity, or the animal clinic kingdom. This represents $422 billion nationally impacted in DEI initiatives. Also, what is threaded within the center of human-centered care or within DEI is your social determinants of health. Looking at that person to who they are. Do they have food sovereignty? Are they in a food desert? Are they employed? Do they have adequate housing, transportation, access and delivery to healthcare services, housing? So it's really putting them, again, mirroring that effect of what's needed for the best outcomes. Again, climate sensitivity or climate change and its impact on human health, that is also a part of DEI in healthcare. When we look at physician diversity, the diversity that is needed to meet the global needs of so many of our patients that are speaking multiple languages, that represent more than one culture, that have more than one value system of what's embedded in their culture and their upbringings and their current status. You can see the need, I'll let it speak for itself, for where there are some gaps that we need to continue to do better at recruitment and retention. Also, that helping hand of nursing and where some of its disparities are, and the diversity trends, and then gender, where we're seeing some uptick on representation, and again, where we need to do and grow better. Outlined in the red, those are your key hot points. We spend $3.8 trillion on healthcare. We have within the DEI, it adds another $1 trillion to the overall health care spending. And the most important part of that is if it's unaddressed. And then this results in $3.5 trillion in savings by 2040 if it is addressed and applied. Some of your best healthcare model opportunities are with ACOs, which are accountable care organizations, patient-centered medical home models, and of course, what we just previously discussed was social determinants of health. That, if you're applying that directly every day through every human interaction of well-being, that is an additional $1 trillion in savings by 2030. And as I'd already alluded to, it can save the most vulnerable populations extending their lives by virtue of zip code and access 5 to 15 years. These are some of the areas. DEI also is inclusive of physician burnout. I'll let that speak for itself. Some of you are probably have chosen emergency medicine down to plastic surgery, but this has been the trend for the last 10 years. This is from 2023, where some of the burnout rates are. And then the workforce advantages of DEI is greater understanding, problem solving, creativity, innovation, satisfaction, loyalty, improved reputation and brand messaging, and career advancement. And what's centered in that is it also eliminates those health disparities. Also within healthcare systems, I've spent a great deal of time with these three pillars: organizational excellence in developing what those key messages are going to be around DEI, how it improves staff retention, well-being, and patient outcomes. Again, patient-centered medical home, social determinants of health, we deal with the wheel. When you do that same thing with the DEI strategies, you can see from employee engagement to workforce recruitment and how you do those algorithms of data reporting. It's all central and all kind of rides on that same wheel hub. Why it matters to physicians: better performance research has proven increased fulfillment tied to the mission and vision and scope of what they're called to do, creates a stronger workforce. It is also known that, from EHR, EMRs to now with burnout, we're finding ways with DEI to simplify it and make it more congruent to strategic planning, that it will hopefully add an additional 5 years to physician satisfaction. And again, connecting it to margin and mission. For patients and physicians, DEI matters because it's increased loyalty, physician engagement, and trust moves at the speed of progress. Progress moves at the speed of trust. And so it builds that accountability as well. It promotes better health and outcomes. Patients will show up and feel more connected. They'll also feel, even if it's through teach back, they feel like they're being listened to, that they're in a safe environment to ask those questions and be more vulnerable. And it allows that opportunity to be all the richer in learning more about the background and communication needs and what resonates. Again, in purple, why is it important for healthcare systems? With those broader impacts of medical organization, it helps us with all population health models. It creates that better synergistic way of applying interventions. It creates less weathering, otherwise known as burnout. It creates the compositional diversity, which is the contextual piece of celebrating and elevating languages and how those crucial observations and conversations can resonate within better healthcare. It creates a positive role model for when we're looking at building a more diverse, robust workforce. It creates opportunities. If I see someone that looks more like the culture and the background that I came from, and I see that they're a success point, that is that propels such a positive message. So those are unique role models for diversity as well. And then 25% are more likely to increase above the average profitability, an increase of 90+ engagement scores with 50% less turnover when there is a strong DEI initiative that's part of the day-to-day strategic planning and operations. I'll let that again speak for itself, but these are some of the advantages within DEI and healthcare. Again, the equity lens is the largest. There are over 6,000 hospitals, 400 healthcare systems, and about 6,000 have some sort of DEI program that is a part of their branding, their marketing, part of their onboarding, their training, their leadership transformation, innovation, and part of their budgetary. The sweet spot is a range between, it starts at, depending on how many employees and the size of the organization, anywhere between 10,000, 216 million, but 1.2 million is, as I mentioned, the sweet spot. The median is generally 50 to 30,000 in DEI implementation costs. And then these are the other dot points of areas in how DEI is spent: training, recruitment, onboarding, marketing and branding, community relations or town hall meetings, data collection and policy development. By not having it, and that's part of the risk management, the legal, the cost could be 315 billion per year not having DEI. Again, these are some of the survey opportunities. This is by Deloitte and Touche, health disparities. Again, this goes back to 2021, so kind of mid-pandemic, and what the thoughts were for DEI. But again, health equity is the top pillar of the focus. Again, addressing those health disparities. And those health drivers that are within health equity are really building a diverse workforce to meet these healthcare needs. Now, I would say that it starts at the top. So uniquely, you'll see at the very bottom, it's the diversity of the board within the C-suite and leadership, but they are main drivers to this commitment. Again, the circle, wheel of trust. This is a checklist I use with all the healthcare organizations that they can readily use daily. So as you would be rounding with patients for patient or human-centered care, where you would be applying the social determinants of health as it relates to DEI, that's the breakdown circle. So determining the implications if you don't use it regularly, assessing your readiness and deadlines, policy, how you can submit it and use it actively within every measurement tool, within your strategic planning, down to your grants, and then analyzing that data, hoping that you will be better the next year than you were this year. Again, policy development, assessment, assurance. These are the other additional components of monitoring, evaluating, assessing, informing, empowering, and educating. Quality. At some point, the American Hospital Association, as well as many healthcare lobbyist groups, are talking about quality measurements being that next level of astuteness and how that can impact some reimbursement models in the near future. But these are the metrics that I have used. This mirrors the Academy of Innovation, HR. Again, great tools to maybe refer to in the near future. These are the opportunities or the checklists that I use within healthcare systems. Who needs to receive all these types of training, where that flow is, the regular consistency, and the maximum outcomes. And then the DEI medical innovations, which was the fifth part of my presentation, is DEI is more purposefully, meaningfully being applied to various ACO pilot models, personalized medicine, also known as precision medicine, virtual healthcare assistance, down to laughter libraries, which are wellness libraries for laughing and wellness, and how they are put together and what those active outcomes are. Medicine for the masses, which is called direct primary care, as well as preventive health care. Additional opportunities are your AI. That'll be a huge focus for DEI moving forward. Your EHR, population health improvements and algorithms. 3D print, which is becoming more important, especially in areas of organ transplants and precision medicine. And of course, mental health or behavioral health, keeping a multi-generational scope, multicultural scope from individuals into family services. Again, that circle, the DEI innovation in precision public health, precision population health, and the areas of precision medicine. These are the greatest opportunities moving forward in innovation for DEI. And then I work quite a bit with healthcare systems, helping young talent or even mid-managers or those that are just entering into the medicine field for some additional DEI and national and international organizations for DEI movements. And those are Doctors Across America, Doctors Without Borders, the National Rural Health Association, which is the NRHA, United Nations Global Health Initiatives, Tribal Health, and Refugee Health Services. And then it takes all of us as a sacred community from self to others to recognize that we're all in this together. So I thank you for your time, both those of you on Zoom that I don't have the pleasure of locking eye to eye with, and those who are front and center this evening. Thank you. I always welcome questions, but in the interest of time, I don't know if you wanted to ask those afterward or if anyone had questions now, I'm happy to answer those. And this isn't just a one-time thing. I do have my contact information, so if you want to reach out to me later, or you wanted to percolate some of these thoughts of what was presented this evening, however works for you.
All right, so it's a pleasure for me to be here and join you all to talk a little bit about inclusion and belonging. I really enjoyed listening to, oh, one second. Can we turn the full screen? I got it. Thank you. So we started off talking about diversity, equity, and inclusion as a in a global standpoint, and we're going to hone in a little bit on inclusion and belonging. I'm a wanderer when I speak, but I because our pointer is not necessarily working in the way that we'd like it to, I'm a little bit hinged here, but I might still wander a little bit, so just bear with me. So inclusion and belonging in an academic setting. When I thought about what that meant for me to talk with you all about, I thought of this quote by a DEI consultant named Arthur Chan. And he says that diversity is a fact, equity is a choice, inclusion is an action, and belonging is an outcome. When I heard that, it really resonated with me because if we think about all of the ways that we have approached diversity, equity, and inclusion, we'll start off with the numbers and what the numbers mean and what how it's important for us to recognize the numbers and move through change. But going further to talk about the acts and the choices and the outcomes made it feel like it completed the way that we consider all of our thoughts in healthcare. We think about the facts and we go from the facts to the actions. We make choices to have some sort of impact on those facts, and then we evaluate the outcomes. And so that's a really nice framework for this work. So when I looked for definitions in the Merriam-Webster dictionary for inclusion and belonging, this is what I found. Inclusion being the act or practice of including and accommodating people who have historically been excluded, with an example of race, gender, sexuality, or ability, and belonging being a close or intimate relationship. So inclusion is that action. We recognize that the numbers, the facts are telling us one thing, and then we are making an action to include folks. And as a result of that inclusion, people can develop relationships and then feel that sense of belonging. My personal mission statement is on the slide here. Because health equity is my North Star, I will transform every space I enter as my authentic, joyful self. And my mission statement has evolved over time, but this is where it's at currently. And I thought it was really neat that I was asked to talk about inclusion and belonging because I recently did StrengthsFinder's survey, and so assessed all of my strengths and found that 5 out of my top 10 were in the relationship building category. And you can see them there: individualization, connectedness, relator, harmony, developer. And so building those relationships, feeling that sense of belonging, those are really important values to me. I always like to start when I have give presentations. I like to showcase some of the people that mean a lot to me. I'm not going to go through who all these people are, but these are folks who have mothered me and cared for me and built relationships with me over my years. And that is kind of what propelled me through that personal mission statement. So we've already heard why we should focus on diversity, equity, and inclusion in healthcare. Okay, we have this wealth of data that we just went through, all of this amazing information about the pros, about the benefits, about the outcomes. And yet we still see that these values continue to be undervalued in our healthcare systems. And when we focus in on the fact from a diversity standpoint, who is underrepresented? I'm not going to spend a lot of time on the facts here today because we had a great presentation about the facts, but there are a lot of people, a lot of individuals who are entering into medical school who look around and they don't see people that look like themselves. We were really fortunate back in 2020. We were finally able to see that from a matriculating standpoint, women were matriculating at higher rates, making up about 53% of matriculants into medical school across the country. That's great, making up for decades and decades and decades of being behind. But this win is a small win. We will take the win. But when we look at the rest of the pathway after people start medical school and we start thinking about residency and then fellowship and then attending positions and then leadership positions and who are the chairs and who are the CEOs, we start to see women dropping off. And so it is not enough for us to celebrate the fact of women matriculating at higher rates into medical school. We need to understand why they do not have those same rates at the leadership standpoint. You can take that same approach to every single underrepresented group, from race and ethnicity to people with disabilities, to members of the LGBTQ+ community. There are opportunities for us to go from facts to actions, to choices, to outcomes. And I believe that medical education training programs definitely have a role to play in this. And so I'm going to talk more about the inclusion and belonging piece and how we can address this at multiple layers across the journey of medical education. So in the pre-medical standpoint, let's think about how we get folks into medical school to begin with. I have your Creighton Office of DIB as an example of the intentional approach for increasing pre-health exposure so that we can have the individuals coming in and matriculating into medical school. In order for us to transform the face of medicine, we have to be intentionally recruiting now for the future of medicine. This is something that it can be difficult to do. We need the resources to be able to do it. And at the same time, we still have a crisis right now with trying to get people to go into medical school right now who are at the age and ready to do it and to continue through to residency programs. But we still got to think about the 8-year-olds, which is why I was so happy to be here on Saturday for the Young Women's Symposium, where I got to meet a group of young women from age 8 through, I didn't ask them how old was the older ones, but there were also parents in the room, and people were so excited and so engaged and asked amazing questions. And maybe some of them will go to medical school, maybe some of them will go to another health profession school. But this is the age that we have to start engaging folks and helping them to see that their opportunities are truly limitless. Some of the women that I showed you in that first slide were women who, when I was that age, I shared on Saturday that I was 8 when I decided I wanted to be a doctor, and it was my family doctor, my pediatrician, who gave me the idea that this was even a possibility. And she just kind of said it, you know, you could be a science teacher or you could be a children's doctor. And her being so casual about, yeah, this is something that you could do, made it so that I never questioned whether or not I would become a doctor. Once I made that decision, I never questioned it. We have to do that for more little ones. We have to inspire them to believe in themselves in a way that maybe in the past they may not have been, but we have an opportunity to do that now. So I really am excited about all of the work that is being done here with these pathway programs to excite and engage the future generations now. So that's in the pre-health exposure. From a residency and postgraduate training standpoint, there are a lot of opportunities to engage folks. And so this is one slide that I will spend very little time on, but encourage folks to go on and take a look at it. This is a scoping review that I had done with a medical student, a few medical students, and they had the question of, well, what are these interventions that are evidence-based that have been shown to be associated with increased diversity in racial and ethnic groups in residency programs. Looked at over 2,000 articles, and there were 2 studies that focused on fellowships, but most of them focused on residency programs. And the median duration of those studies was about 4 years. And so they had a good amount of time to watch and see what those outcomes were. And on the right-hand side of the screen is the list of the big themes of what are the different types of interventions that residency programs and fellowships can do from a graduate medical education to really increase the numbers of folks from minoritized backgrounds that are coming into their programs. Some of these things that are already happening right here on this campus, and we already talked about pathway programs, but some of the issues that we saw come out as themes was, how can we demonstrate visibility? How can we demonstrate a culture change and show folks who are interested in joining a graduate medical education program that they can belong there, that they can see themselves there, and that they might be able to thrive? So this is why it's important for us to support these diverse workforce, and that requires us to have structure with programs that are put in place that are designed exactly for this purpose. Not only for looking at the numbers and the facts, but also assessing what are the actions that we are implementing to be able to influence those facts, and whether or not we are achieving those outcomes that we really would like to achieve. What is the support system that people have once they actually start? We talked about where women, for example, will be dropping off as they move along into their career. How can we create a more robust support system for those individuals so that they don't drop off? How can we build connections between individuals who are in the program as well as our employees and our communities, so that whenever we do go back into the community and try to encourage people to come in, we have an established relationship? Because it's one thing to have the ideas, and it's another to actually go out into the community and talk to people and have them trust you enough to engage with you in that way. Under resources, what's important is providing resources for the few that already exist, so the few people from underrepresented backgrounds to be able to engage in this work in a meaningful way, but not be the only ones doing it. The minority tax is real, and it is something that, as we build programs to try to create more inclusive environments, we have to be mindful of that minority tax, especially when you got people who are really excited about doing the work and may not themselves recognize the added burdens that they're putting on themselves. As leaders, there are opportunities to help to provide those resources. Developing by building expertise, and then all of that into the sense of belonging, that outcome that we're hoping to create. So in the last like 10 minutes or so, I just wanted to share a couple initiatives that I've been involved in at UNMC that help with building an inclusive environment and fostering a sense of belonging with the context of curriculum building. I think we all have experience with creating inclusion and belonging through some of the things that we've talked about, like pathway programs and making sure that there are individuals who are representative on different committees. One of the realities of healthcare training is that we're in a classroom a lot, we're learning a lot, and there has to be a way for us to be able to translate inclusion and belonging into healthcare in the language of curriculum. So this is what I get fired up about, and I'll tell you a little bit about that. So one of my former roles was Associate Program Director of the Internal Medicine Residency. I did that for 5 years and completed that role this June. And one of the capstone initiatives that I developed during my time was the Diverse Council, developing an inclusive and varied environment for resident students and educators. And this is a largely resident-run council. We have maybe 3 or 4 faculty members on there, mostly residents, a few fellows, and some medical students. And we have some chief residents as well. And the group came together in, I would say, towards the end of 2019 is when we started putting everyone together. And it has changed over time as people have graduated, but our goals have been the same and our priorities are the same, looking at what are the residency programs' approach to their selection processes that is directly going to impact the diversity of our residency program through selection committee reform. How can we be intentional about recruiting by going to places where people are and talking to them about Omaha and Nebraska and UNMC and making it so that they, wherever they are, they're thinking about us? What is our role in creating a space that people always feel included, people feel a sense of belonging within the residency? How do we do that through education? And how can we provide our group and our community in our residency program, as well as the department, the resources that they may need to help with their own education? So a couple things that I will share about what we've done with that. Going to where they are was a really important piece of this. And so prior to launching the Diverse Council, our residency program did not attend national student meetings for the purpose of recruiting. Since launching this initiative, we have been to many of these meetings. And SNMA is one that we have gone to for the last 3 to 4 years. We've been going to LMSA meetings, and we try to go to regional as well as the national meetings. And one of the important things about the way that we do this that promotes a sense of belonging is typically we have one faculty member who goes, and then the rest are residents. And the residents are empowered, they're excited, they want to be out there doing the recruiting. And your best recruiters are happy residents, are residents that think that they are in a place that values them, that they belong, and that they are thriving. And so this is something that is completely voluntary, and every year we have a list of residents who want to go. We have some students as well, and we have to kind of decide who gets to go where, because it's such a popular opportunity that they'd like to do. What they came back one year to say to us was that by going to these conferences, not only did they feel like they were contributing to the programs, but they were also themselves having, coming back with a newfound kind of a renewed excitement for what they could be doing in our residency program, because they had a chance to network and connect with people at those conferences. Inclusion and belonging has to do with how a person feels in the space that they're at, and being flexible enough that folks can come back with ideas to say, we want to do this or we want to try this, and we value what those ideas are and make the effort to implement them is an important piece of that. So switching gears, I'm going to talk a little bit about how we change culture with curriculum. We've done this in a couple of different ways. Starting off with some of the work that I've done in the medical school, building structural competency through community engagement. Now you might ask to yourself, well, what does curriculum have to do with inclusion? And the story that I will tell you is, as a result of what we did with this particular initiative, this is something that a medical student, maybe 5-6 years ago, came to me and said, you know, Dr. Marcelin, I'm from Omaha. I have been here. I grew up here my whole life. And it's really frustrating that when we're in class and we're learning about our community, we're not really learning about our community. We're not learning from our community. We're not really talking about the things that are really impacting our community. And I know this because we never once talked about the food deserts that people have to walk however many miles in order for them to have access to fresh food or things like that. We were learning about things in a vacuum. And so with that gap identified, we kind of worked together to build the structural competency curriculum that involves, as you can see on the screen, different lectures that are didactics, but the capstone of that is a community engagement day where we spend time with members of the community. What it looks like today has evolved from what's on the screen, which is part of the publication that we created for this initiative. And today it's really exciting because the students will spend 2-3 hours with different community members, and they will, you know, go off and do whatever the community members are doing. So mine that I'm paired with is Pastor Reverend Portia Cavett. And so we go to her church, and depending on the time of year, the students will be talking about how we can help with building the baskets for the food pantry that she's going to have that week, or we'll be out in the garden helping to harvest food, or we'll be planting stuff. And that's initially helping the students to get a chance to understand what it's like to really contribute to their communities. But even during the lectures, I've gotten feedback that the work that has been done to evolve the approach to delivering the lectures has made a difference. One student texted and said, I just really appreciate that you took the time to name structural racism in a lecture and talk about why people may make different health decisions and not blame individuals, but acknowledge what are the different reasons why those decisions are being made, and talk about ways that we as healthcare professionals can contribute to changing that. In that moment, that student felt seen. They were sitting in a bunch of different lectures for however many months that they had been in med school in their short time. And that was the first time that they had heard somebody talking about these things. That is an act of inclusion, right? And if, as educators, there are opportunities to include that into each of our work, then we can build inclusion one lecture at a time. We have a curriculum in the residency program. So that was medical school. So we have a curriculum in the residency program called Jedi with Jasmine. And that's a program that some residents and I developed, where because the WAMC does have requirements for us to include an understanding of equity and inclusion in our residency curricula. There needed to be a way for us to formally include this. That wasn't going to be a one-off. And so this is a monthly noon conference lecture that is a part of the residents' 18-month curriculum, and they come to expect it every first Monday or second Monday of the month. And what we've done with this program is we use a case-based approach where residents will bring cases, things that they have experienced, things that they have witnessed and seen on the wards, where they're like, man, if we had only done this, I wonder what would have happened. Or why is it that it took so long for us to be able to discharge this patient when, for this other patient with a similar condition, we didn't have those problems? And they would bring those questions in, and from those questions, we put together a session that has both the case presentation as well as structured breakout sessions so that residents can explore some of these questions together, and they're facilitated. And then we have a rapid review of resources that are evidence-based as well as practical resources. So for example, for one of our sessions with patients with limited English proficiency, we have an app in our hospital called Propio that we usually will access those interpreters on the phone, but sometimes it takes a while to get to them. People didn't know that there was an app, and that was a tangible thing that they could get and take with them to the next patient encounter for a patient with limited English proficiency. This curriculum has been going for about 3 years now, and we've been doing an ongoing assessment of this, and our residents are feeling like their confidence in their ability to address structural determinants of health and addressing bias and discrimination at the bedside or amongst peers is improving over time. And what I have noticed as an infectious disease doctor who's rotating with these residents is that their language changes, their whole vibe changes, right? And so we're now at the point where we're presenting a patient, and as part of their presentation, even though we're talking about a very complicated infectious disease syndrome, those residents are also talking about what's the discharge going to look like for this person. I'm concerned about their ability to be able to come back and get this medicine. Are there alternatives? What can we do to think about, be creative about getting them the things that they need to be successful in their health? And this is all through making the inclusion just a part of the education process. Our residents who are from minoritized backgrounds, who have been increasing over the last several years, feel like they can have those conversations with their colleagues because during a Jedi session, we're all just in it together and we're learning together. And it's not one person having to teach another every single time. It's the entire group that's doing this learning, and they're coming out of it with these positive impacts. The feedback they've given has been really positive, focusing on how having these open discussions in this type of setting is really helpful, making it a safe place to discuss uncomfortable things, including injustices in healthcare, and helping them to develop the language that they need to be able to continue those conversations outside of the classroom. So don't forget faculty, right? So we talked about pre-health, then we talked about med students, and then residents, and then faculty is the next important piece where inclusion and belonging really needs to be a part of a healthcare organization's interest and priority. We need to be able to build these communities for our faculty so that they have the ability and the bandwidth to mentor the trainees who need that mentorship coming along. One of the things that there's been a lot of data that has been described looking at faculty from minoritized backgrounds and what their experiences are in healthcare. And you find that, again, to the discussion of the minority tax, there's a lot of mentorship that is happening. People are mentoring. If you're the one Black faculty in your department, you're mentoring all of the Black students, okay? And that's kind of, it's expected. It's kind of an unspoken thing that you want to make sure that you take care of your babies. But if you've never received any mentorship training, if you are the only one that's doing it, and the number of students that are out there are increasing, then there needs to be some sort of way to support the faculty. We also have to support faculty who might not be from minoritized backgrounds, who want to support the students and the residents who are. What is the training that needs to go into that to ensure that there is culturally appropriate training and professional development? And so two programs that I've seen doing this really well that I'd love to be able to emulate. One is this BEAM program, Building Equitable Access to Mentorship at University of Wisconsin. So that's a really great faculty mentoring model that helps to build a community, an inclusive community for both faculty as well as the trainees by a stepwise ladder approach of mentorship of senior and junior faculty mentoring the residents, who's mentoring the medical students, who's mentoring pre-meds. And so it's a really fantastic approach to building inclusion. And then this program is the Transform program that I am a part of, this third cohort, which is a national program that focuses on mid-career minority faculty with similar goals of developing career mentorship and leadership skills so that we can then go on to mentor the next generation and build that resilience through those shared communities. What does it mean to have justice, equity, diversity, inclusion values in an organization or in a department? It feels like authenticity, it feels like belonging, it feels like community, and so much more. One thing that I would like to say, all what I just talked about was within the context and the confines of our academic institutions and the four walls. I did talk a little bit about community engagement, and that is something that is so important to me. And a lot of what you're seeing on the screen is a result of some of our community engagement opportunities. And then there's opportunities in the community for building inclusion and belonging so that you have a way to fill your cup outside of the hospital. And for me, that's my Omaha Mocha Docs. Shout out to my sisters. We created this community together of women who have different doctoral professional degrees to support each other. And I think pockets of support groups like that pop up and build outside of the institutions can really help to bolster that sense of community and inclusion and belonging for those faculty once they're inside those institutions. And so that's another really important thing. Just wrapping things up, always thinking about involving trainees, being resourceful about how we do the different initiatives, being mission driven, going back to what are the overall mission and what's our goal for DEI, and being intentional about every single touch point is important. This is a quote of somebody who I interviewed with very recently for residency. And this young lady said to me, "I was so excited to interview with you. You are the only woman of color who has interviewed me of all my residency interviews." And I was astounded that she had to come to Nebraska to be interviewed by the first woman of color. I mean, all right, go UNMC, but still, that shouldn't happen, right? There should be opportunities for engagement, recruitment, and retention of people from minoritized backgrounds across all of our institutions. And so we really have to do a lot of work. Once we get people to be recruited, we've got to do the work to keep them here because being the only can be lonely until others see themselves in you, and then they can join. And that I will end. Thank you very much.